I used to think that Hadassah and Hebrew University were the best academic institutions in Israel, but now I'm happy to say that our institution has the most Nobel Prize winners in Israel, so I feel even better now. Anyway, we'll switch from the mitral valve to the tricuspid valve, which I think I will convince you that it's not forgotten anymore. And I want to start with a case. 48-year-old woman with rheumatic heart disease and mitral stenosis. She had closed valvotomy when she was young, and then at the age of 45 she had a mitral valve replacement. After surgery she had a complete AV block and symptomatic bradycardia, so she got a pacemaker. Pre-operative she had mild TR. She didn't have a mitral valve repair during the operation, and tricuspid regurgitation, sorry. And then she quickly developed a significant tricuspid regurgitation after surgery, and 3 years post-operative she had severe TR without any pulmonary hypertension, and she was severely symptomatic. And she came to me, and you can see the right ventricle, which is dilated. The tricuspid valve leaflets are severely restricted, and there is malcoaptation. You see the pacemaker lead. The right ventricular function is excellent. TAPSE is 2.8 centimeters. And this is the RV inflow view. You see that the inferior leaflet is severely tethered, and there is severe tricuspid regurgitation with hepatic venous systolic flow reversal. And with the 3D TEE, you can see the pacemaker lead, which is lodged in the sub-tricuspid apparatus. And I had a very strong feeling that the TR was related to the pacemaker. I tried to convince our EP guys to pull the electrode out. They didn't want to do it. They said it's too dangerous. They can tear the leaflets and the subvalve apparatus. And also, I suspected that during those years she also developed tricuspid annular dilatation. So we went to surgery. And during surgery, actually Boris is here. He did the surgery. You can ask him why we don't have pictures from the surgery. During surgery, what they found was that the pacemaker electrode pierced the papillary muscle, and the leaflet, and then they tethered the tricuspid valve. And once they took out the electrode, leaflet sprang back and the valve looked completely normal. So they did the repair, and post-operative put the ring in, and post-operatively there was no TR. And now 1.5 years later, the patient is doing extremely well. She is completely asymptomatic. RV went back to normal. There is maybe mild to moderate TR in this view. And from what I'm going to show you, if we didn't do that surgery, the outcome would be completely different. And this would be a matter for another session for the heart failure people that we know that how their patients look like. So now we know that TR carries grave prognosis. This is data for over 5,000 patients referred for echocardiography in VA hospitals. And you can see that patients with TR have much worse prognosis than patients without TR, irrespective of left ventricular function or pulmonary artery pressure. Not only that, if you look at patients after mitral valve replacement, you can see that moderate or severe TR carries a grave prognosis, and the hazard ratio for heart failure and death is 2.5 or 2.2, and those patients don't do very well. Now, what is the incidence of TR in those patients? In rheumatic patients, it's anywhere between 25 to 40% after MVR, and it usually takes about 10 years on average, but it can be anywhere between 1 to 30 years for TR to develop. In ischemic MR, there is at least one paper that shows that it's also very, very common, but it's much less common in degenerative MR. This is data from Alex Sagi. I'm not sure it's already published. Now, if we just remind ourselves a little bit about the anatomy that we see with the transthoracic echo. In most views, we see the septal leaflet, like in 4-chamber view, we see the septal leaflet and the anterior leaflet. Only in the RV inflow view, we can also see the posterior leaflet over here, and this is the anterior leaflet. With TEE, again, besides the septal and the anterior leaflet that we see in the mid-esophageal view, in the 110 or 120 degrees view, in the mid-esophageal view, we can see the posterior leaflet down here, the anterior leaflet up here, in the same way in the transgastric 120% view, posterior, anterior. We can also have a short axis view. This is a transgastric TEE view, and you can see the entire tricuspid valve, and you can also see it with 3D echo, but I must say that it's very difficult to get this view, at least in my experience. Now, what do we have to look at when we assess the tricuspid valve? We look at the leaflets for thickening, doming, or restriction. We look at the coaptation of the leaflets. We can also have flail tricuspid valve leaflets. We measure the annular diameter. We look at gradients, mean gradients, to see if the valve is stenotic. And of course, we look at the consequences, right atrial and right ventricular dilatation and septal flattening. And we assess TR severity. How do we assess TR severity? First of all, it's the easiest valve to assess clinically. You just look at the patient. If he has a giant V waves, if he has a pulsating liver, he has severe TR. You don't have to worry about it. You also look at the anatomy. If it has a severe malcoaptation, you don't even need to bother turn on the color. You look at the dilatation of the right side and the inferior vena cava, large jet area, a vena contracta above 0.7 centimeter also is a severe TR. You can look at PISA. Not many people do it at 20, an equus of 28 above 0.9 centimeters. The CW signal is usually very dense and triangular. And you have systolic hepatos-venous flow reversal, which correlates very well with giant V waves. Now, what is the pathogenesis of TR in mitral valve disease? Well, you can have rheumatic heart disease or dilated cardiomyopathy or ischemic MR, and all these lead to mitral stenosis or mitral regurgitation, which cause dilated left atrium, increased left atrial pressure, secondary pulmonary hypertension, which cause eventually RV dilatation and failure. This causes tricuspid annular dilatation. Increased left atrial pressure causes it to dilate, and it causes left atrial fibrillation, which again which can be caused also by RV dysfunction, and it causes again tricuspid annular dilatation. I will show you that atrial fibrillation is a very strong predictor of tricuspid regurgitation, and all of these, tricuspid annular dilatation and the tethering from RV dilatation, they cause tricuspid regurgitation. Organic leaflet involvement with rheumatic heart disease can also cause tricuspid regurgitation, as I showed you, pacemaker leads. I think this is very much underestimated. I think those leads cause much more TR than we suspect. Now, we used to know that if you refer a patient with late TR, isolated TR, to surgery, those patients do very, very badly. This is one paper from Boston. from about 11 years ago, a small number of patients, only 15, but the outcome was terrible. Median survival was 1.2 years, and there was also no symptomatic improvement. Now we see data from other places where they sent patients earlier. This is data from Korea 2 years ago. They looked at 61 patients, usually young females, with mostly rheumatic heart disease. And in their experience, the prognosis was much better. Early death was only 10%, and late death at 5 years was also only 5%. And also, patients who were sent early, before they had RV dysfunction, when the end systolic right ventricular area was less than 20 square centimeters, and before they developed anemia, prognosis was much, much better. Well, this paper had the limitation. Of course, they don't have a control group. Most of the patients got a prosthetic tricuspid valve, which is also a problem, and we don't know the long term. But I think the message is clear. If you send those patients early, they do much better. If you wait, they go to our heart failure colleagues. Does TR resolve after correcting the mitral valve lesion? People used to think many years ago that this is the case. We know that it's not. This is a patient after successful mitral balloon valvuloplasty. He had severe TR before and severe TR 1 year and 8 and 6 years after the procedure. And we know that it is very common, between 50% to 80% of patients who have successful balloon valvuloplasty. Who can we send to mitral valve valvuloplasty, balloon valvotomy when they have TR? Maybe younger patients who don't have chronic disease, no atrial fibrillation, which their TR is functional without significant organic changes, and patients who have severe pulmonary hypertension, secondary pulmonary hypertension, and good RV function are the best candidates, because after the mitral valve valvotomy, the pulmonary pressure goes down, and there is a chance for the TR to get better. We know from several papers that the predictors of TR after mitral valve replacement are the etiology. Rheumatic heart disease patients tend much more to get late TR, and we should be very aggressive with the concomitant tricuspid valve repair. If they have more than mild TR, atrial fibrillation, I think, is a very, very strong predictor in all the studies. And if those patients have atrial fibrillation, they should either go have MACE or have a tricuspid valve repair, and better both. Very large left atrium also is a predictor. Most of these patients have atrial fibrillation. It signifies chronic disease. Interestingly, preoperative pulmonary artery pressure in most of this study was not a predictor of late TR. And this is one paper. It also has many limitations, but it shows that in patients who had concomitant waves, those who stayed in sinus rhythm had did not have TR progression, as opposed to patients who did not have MACE. What about the tricuspid annulus? This is a paper from Boston when Alex Agi was there. And how do you measure the tricuspid valve? You measure it in 4-chamber view at the end of diastole, from the insertion of the anterior leaflet to the insertion of the septal leaflet. Normally, it's about 2.8 centimeters. And in patients with severe TR, it was more than 4. And they found that the tricuspid annular diameter was the burst determinant of TR severity, not to pulmonary pressure, not even RV function. And the solution is to put a ring in, much better in the original operation. This is one example of a 3D ring that tries to mimic the normal tricuspid annular geometry. And this is probably the best paper, and I think maybe even the only paper who supports this approach. It came from Dr. Dreyfus in United Kingdom. He took about 300 patients who had mitral valve repair. Interestingly, a lot of those patients had degenerative MR, by the way. And what he did is that at the operating table, he measured the tricuspid annulum. And if it was more than 7 centimeters or more, he put a ring in. This correlates to about 40 millimeters with the echo measurements that we do. And he ended up putting a ring in about half of his patients, which is a lot. There was no big difference in operating mortality or 10-year survival, but at 10 years, functional capacity was better in the patients who had a ring. None of them was in functional capacity 3 or 4, while 14% of the patients that didn't get a ring were in poor functional class, although they were sicker patients to begin with. Okay, a less sicker patient because they have a smaller ring. And almost none of them had significant TR, as opposed to a third of the patients who did not have a ring. And the conclusion might be that you should even put more rings in at the initial operation. There is also data to show you that a ring is better than doing just a De Vega, although that I know that some of the surgeons don't agree with it. And if you put a ring in, there is much less chance of getting late TR as opposed to De Vega. What do the guidelines say? Well, not very encouraging. The ACC-AHA guidelines give only a 2B indication for tricuspid annuloplasty. It may be considered for less than severe TR in patients undergoing mitral valve surgery when there is pulmonary hypertension. I just showed you that there is nothing to do with pulmonary hypertension for late TR, or tricuspid annular dilatation. The European guidelines give a 2A indication for moderate organic TR in patients undergoing left side valve surgery, and moderate secondary TR with dilated annulus, about 40 millimeters. This is from the Dreyfus paper, in patients undergoing left side valve surgery. And personally, I think we should be much more aggressive. It takes only 10 minutes. We'll hear about it from the surgeon. Usually, there are no complications, and the outcome is much better. So in summary, moderate or severe TR predicts heart failure and death, especially after MVR. Late TR after mitral valve surgery without tricuspid valve repair is common in rheumatic heart disease and may appear years after the surgery. Late TR is also common in ischemic MR, but less common in degenerative MR. Preoperative TR predicts poor prognosis and may not resolve after the mitral valve surgery. Most commonly, late TR is functional and isolated secondary to tricuspid annular dilatation, plus minus rheumatic changes. A tricuspid valve ring annuloplasty should be performed at the time of the initial mitral valve surgery, and you should definitely avoid late surgery. Don't refer patients too late when they already have a severe heart failure and irreversible changes. Select patients for tricuspid valve repair based on etiology, presence of atrial fibrillation, more than mild preoperative TR, and we recommended a tricuspid annular diameter of 3.5 centimeters or more, although there is very limited data for that, and a very large left atria, and consider concomitant MACE in patients with atrial fibrillation.